thyroid gland is a butterfly-shaped bilobal structure, typically located anterior to the trachea. It secretes a thyroid hormone T3 and T4 for regulating the body's metabolism. So this is general biological rules of thyroid hormones, which regulate the basal metabolic rate, stimulate the CNS development and physical growth, and also increase heart rate and myocardial contraction, support the reproductive health, and also promote drug clearance. So, how thyroid hormone is synthesized? Firstly, there is a functional unit of thyroid gland known as the follicles, which consists of the follicular cell, which produce and secrete the T3 and T4. And also, apart from that, thyroid gland also consists of the parafollicular cell, which secrete the calcitonin for the protein involved in the calcium hemostasis. So this is the general idea of how thyroid hormone is synthesized based on the 4 steps. First one is the iodine trapping, which is the production of the thyroid hormone is initiated by the absorption of the iodine from the GI tract, basically from our diet, where the iodine is reduced to iodide and released into the bloodstream. And the follicular epithelial cells take up the iodide ions from the blood through the sodium iodide sympater. So the iodide uptake is inhibited by the lithium, which compete with the sodium at sodium iodide sympater. I'm going to explain this part later in detail. And then next one is the iodine ice oscillation, which is iodide is transported through the follicular cells into colloid by pendrin, a transporter protein located at the follicular cell surface. So once in the colloid, the oxidation of the iodide by the thyroid peroxidase forms the active iodine. And then this one is important because anti-thyroid drugs like propylthiouracil and also metimazole inhibit this step, which is the oxidation of the iodide by the TPO. I'm going to explain this one also further detail later. And then next one is the thyroxine iodination and the coupling. The active iodine binds to the thyroxine residues of the thyroglobulin. Under the action of the deiodinase, form the 2-iodotyrosine, and then the further iodotyrosine undergoes subsequent coupling with the TPO to generate T3, T4, the thyroid hormone, both of which are stored as the colloids in the thyroid gland. And then the last step is the endocytosis of colloid, which is the release of the colloid as the thyroid hormone into the circulation by the fusion of the endocytic vesicle containing the thyroid hormone itself. So, the general idea of the regulation of the thyroid hormone synthesis actually is by the hypothalamic pituitary axis, in which the initial stimulation is by thyroid releasing hormone, which signal the anterior pituitary gland to release TSH. TSH in turn stimulate the thyroid gland to release T3 and T4. And the increase in the T3 and T4 level bring back on the negative feedback, stimulation on the anterior pituitary and suppress the TSH. And then the lower plasma TSH concentration result in the decreased production of T3, T4 by the thyroid gland, thus decreasing the free T4 concentration. So what is thyroid storm? Thyroid storm is an acute life-threatening hypermetabolic state induced by the excessive release of thyroid hormones. And then it is also a life-threatening thyrotoxicosis characterized by the multi-system disorder. Mortality rates is in the range of the 11% to 25%. So the etiology of the thyroid storm, most thyroid storm result from the triggering event in conjunction with the underlying hypothyroid condition. Means the patient already have the underlying hypothyroid condition, most likely to have thyroid storm, which is grave disease, solitary toxic adenoma, and toxic multinodular goiter. And then also the major precipitating events for thyroid storm can include non-compliance or discontinuation of the anti-thyroid drugs, severe infection like pneumonia, upper respiratory tracts, and also entry infection, local blunt penetrating or surgical trauma to the thyroid gland, excessive administration of the iodinated contrast radioactive iodine, myocardial infarction, and also diabetic ketoacidosis. So how the patient will be presenting in thyroid storm case? So first one is the thermoregulatory. Patient will be presented with the high grade fever, more than 38 Celsius, diaphoresis. For the related, patient will be presented with the anxiety, restless, confusion, agitation, delirium, acute psychosis, seizure, stupor, and coma. For the cardiovascular, patient will be presented with the tachycardia, heart rate usually more than 140, hypotension, atrial fibrillation, and also congestive heart failure symptom. For the GIT, patient will be presented with the nausea, vomiting, diarrhea, acute abdominal pain, and also hepatocellular dysfunction, for example, like jaundice. So how to diagnose thyroid storm? The diagnosis of thyroid storm is made actually clinically, and it may be challenging because the symptom is wide. So as often there is an overlap with the clinical features of the other critical medical condition. So because of this, there is two objective diagnostic methods being introduced lah. First one is the Birch-Watowski point scale and Japan Thyroid Association scoring. So for the Birch-Watowski diagnostic criteria for thyroid storm, there is a few heading, like 7 heading for this scoring method. Thermoregulatory function. So based on all of this, we have to identify the scoring of the patient based on this, and then the scoring of more than 45 and above will indicate thyroid storm. 25 and 44 indicate impending thyroid storm, and less than 25 indicate that thyroid storm is unlikely. For the Japan Thyroid Association scoring, for this one, it categorizes patient into thyroid storm 1 and thyroid storm 2 with the presence of thyroid toxicosis as a prerequisite. And then a few explanation of both of the scoring. Both the Bush-Watowski and the Japan Associated Diagnostics tool can be used to aid in the diagnosis of the thyroid storm. But the Bush-Watowski scoring is more recommended as this scoring tool is more sensitive. Bush-Watowski scoring of 45 and above or Japan Association scoring of 1 is definitely for thyroid storm and require the aggressive treatment. And so on for this next one. So if patient present with suspected of thyroid storm, the investigation include laboratory investigation, baseline blood investigation, include CK. And then the finding can be patient will be presented with hyperglycemia, thrombocytopenia, leukocytosis, hypercalcemia, and elevated liver enzyme, raised CK. Thyroid function test also will be T3, T4 will be elevated. And although the measurement of the T3 and T4 are required, this value actually may not correlate with the severity of the clinical presentation. And treatment should not be delayed even if TFT result is pending. As far as thyroid storm is suspected clinically. For the imaging, we can do a chest X-ray. Patient it may reveal cardiac enlargement due to congestive heart failure. May also reveal pulmonary edema caused by the heart failure. CT brain may also be needed to exclude other neurological condition if diagnosis if uncertain after the initial stabilization of the patient. Okay, we move on to the treatment of thyroid storm. Actually, there is 5 objective treatment for the thyroid storm. First one is to inhibit synthesis and release of thyroid storm. Second one is inhibit peripheral action of thyroid hormone. Third, reversing systemic decompensation. And fourth, treating precipitating event. And the last one is addressing definitive therapy. So the first one, anti-thyroid drug of choice in thyroid storm. First one is the propyl thiouracil. Propyl thiouracil and metimazole. fulfill the first objective, which inhibit the synthesis and release of thyroid hormone. Profit Thiouracil doses is 500 to 1000 mg loading dose, then 250 mg 4 to 6 hourly lah. And then metimazole can also be used in the presence of contraindication of profit-thiouracil with a dose of 60 to 80 mg per day. And upon improvement of the thyroid storm, patient should be transitioned from profit-thiouracil to metimazole. And it also be said that metimazole has the added benefit of less frequent dosing of and less hepatotoxicity because profit-thiouracil upon administration of it, we have to monitor for the liver enzyme in view of suspected for hepatotoxicity, the side effect lah, rash and also granulocytosis. Indication where the absorption of oral PTU and also metimazole is compromised, for example, such as in ventilated patient or those patient with the impaired absorption, we can change to rectal profit-thiouracil or metimazole. For example, profit-thiouracil enema, also profit-thiouracil suppository lah. Next one is beta-adrenergic receptor antagonist. For example, propranolol. 60 to 80 mg QID. This medication it inhibit the deiodinase and are key to control the heart rate and inhibit other peripheral action of thyroid hormone. Caution should be exercised with patient in decompensated heart failure lah. Next one is selective beta-1 blocker. For example, esmolol. It control heart rate and have more favorable cardiovascular benefit lah in thyroid storm with significant cardiac compromise. And the last one is CCB, cardio-selective calcium channel blocker. For example, diltiazem. It also control heart rate, and if there is a contraindication to beta blocker, such as in patient is blocker asthma or COPD, this one can be administered lah. Okay, next one, corticosteroid. Example, IV hydrocortisone and also IV dexamethasone. This medication inhibit both thyroid hormone synthesis and peripheral conversion of T4 to T3 lah, the active form of thyroid hormone. It also been given as a prophylaxis for relative adrenal insufficiency caused by the hypermetabolic state in thyroid storm. And also anorganic iodide, like for example Lugol's iodine. It rapidly decreased T4 level through inhibition of iodide oxidation and organoification and inhibit the release of thyroid hormone. It should only be given at least after 1 hour of anti-thyroid drug administration. And after clinical improvement of the patient, the Lugol iodine should be tapered and stopped before the anti-thyroid hormone. Lugol iodine should not be given beyond 10 days or as this would lead to escape from the Wolff cycle phenomena. So for the adjunct treatment for thyroid storm, like I mentioned before, we can give lithium for patients who cannot tolerate metimazole or profit-thiouracil. It works by inhibiting the release of thyroid hormone by thyroid gland. By competing with the sodium at the sodium iodide sympater, thus prevent the iodide uptake into follicular cell of thyroid gland. The adverse effect that need to be considered are lithium toxicity and nephrogenic diabetes insipidus. Next one is cholestyramine. It has been used as an option to improve thyrotoxic state in thyroid storm by reducing enterohepatic recycling of thyroid hormones. So for the reversing systemic decompensation, we can administer with total plasma exchange. There are two types of replacement therapy, which is through fresh frozen plasma, FFP, or albumin. And it is used in patients with severe thyroid storm, rapid clinical worsening or failure to standard multimodal therapy lah. And it is considered when thyroid storm shows no improvement within the 24 or 48 hours of standard anti-thyroid treatment. Total plasma exchange 40 to 50 ml per kg of replacement fluid has demonstrated to remove thyroid hormone antibody and circulating cytokines, thus improve the outcome and resolution of the thyroid storm, and should be continued until the clinical improvement are noted. For supportive therapy and also treating the precipitating event, I mean, this one is more to stabilize the patient and supportive therapy include intravenous fluid, respiratory support and nutritional support. For the cooling measures, using cooling blanket and with the use of the acetaminophen is recommended, like if let's say patient have fever or what. Infection should be treated with broad spectrum antibiotic. Respiratory support with invasive or non-invasive ventilation may be required in patient with respiratory failure or severe neurology depression. For the definitive therapy, urgent or early thyroidectomy is an option in patients who have a contraindication to anti-thyroid drug or have a large goiter. However, this patient should be rendered close to euthyroid prior to surgery with methods such as total plasma exchange in order to minimize risk of thyroid storm. Commonest precipitating factor is non-compliant and patients should therefore be educated on this aspect. That's all for my presentation, Dr.
Okay, ada apa-apa soalan kepada Rahim? Seperti biasalah, tak ada
Any
soalan.
question?
Okay, so basically this is thyroid storm lah. So thyroid storm is something that you need to keep in mind lah bila tengok patient, especially young patient yang datang macam ada a combination of features lah, especially ada AF, ada temperature and not known to have any heart problem or apa-apa sebelum ni lah. So you need to start thinking about thyroid storm lah. Tapi just because berfikir pasal thyroid storm, janganlah semua patient AF korang kira Birch-Watowski pula. Kan? Macam nanti semua pula diagnose as thyroid storm. So kena tengok lah. It's something to keep at the back of your mind, especially in young patient yang with unexplained macam multiple symptom kan. AF lagi, temperature lagi, heart failure lagi, macam, so kena consider. And especially in patient yang memang known to have some history of thyroid problem or memang datang-datang memang ada goiter. Kan, population kita ni masalahnya bukanlah masalah, sebab syariah compliant semuanya, pakai tudung. So sometimes these people can get away with goiter yang kecil dan sedang. Kadang-kadang patient pun tak perasan dia ada goiter kan. So until bila korang buka tudung tu, tiba-tiba kadang-kadang besar sebenarnya goiter tu. So it's important lah to examine patient properly and expose lah. Okay, bukan saja-saja nak buka tudung. Buka sat tengok lah. Dan if you happy tak ada goiter apa semua, okay lah, tutup balik. Okay, so these are something yang selalu miss kat tempat kita. Sebab kita, biarlah dia pakai tudung kan. Sekali tiba-tiba buka tudung, masa nak masuk ward lah, barulah nampak ada goiter besar kan. So it's something that you need to keep in mind lah. And Birch-Watowski tu bukanlah nak kena suruh hafal, tapi at least tahulah Birch-Watowski tu apa. Sebab kalau terfikir, handphone semua ada di tangan, so bolehlah cari. Kalau Birch-Watowski tu pun tak terfikir, dan macam mana nak cari kan, online calculator for Birch-Watowski. Okay, lagi kawan-kawan ada nak tanya apa-apa?
Dia nak tambah sikit. I think recently we have one mortality due to the thyroid storm lah last week. Kalau ingat kan ada satu ibu pada sister kan yang pass away last week sebab thyroid storm. Actually kalau ikutkan patient ni memang dah high risk daripada dia punya rawatan kat hospital pantai lagi. The suspect patient have thyroid storm, waiting 44 tests. But at the same time patient underwent dia pergi CT scan dan diberi kontras. Nampak tak? And then bila datang kat kita dengan full blown thyroid storm, patient already altered sensorium, datang dengan fast AF, sepsis, memang dia ada vomit prior to that dah, daripada dia dama daripada hospital pantai, and then we trace the result noted dia punya thyroid function is 100 plus. Nampak kan? Kalau left untreated for few days, memang it is a very high risk mortality. But kalau kita dah delay treatment, memang susah lah. Bagi nak inhibit all the synthesis because dia dah pergi ke sampai dia punya complication dah. Jadi kena bear in mind especially orang tua atau dah tahu known history of thyroid disease yang untreated ataupun memang dah defaulted. Kan the most common thyroid storm ni happen in uncompliant patient. And kena bear in mind walaupun dia non-compliant mesti ada precipitating event macam patient ni jugalah. Okey ke? Dengar ke?
Dengar.
Okay.
So this is
Okay,
something thyroid storm ni dia macam pulmonary embolism lah. Kalau korang tak terfikir, korang tak tanya the right question and korang akan miss. So it's something that always kena ada lah dalam minda suspicion. Okay.
Okay, boleh proceed ke next presentation. Good presentation from Rahim.
Okay. Thank you, Doktor.
Okay, no problem.